Alrighty, so this is section 2 of the endocrine system for preparation for the AANP exam. So moving along, we finished up with the thyroid section, and now we're going to move on to the Cushing and Addison. How do you differentiate between the two? How do you tell them apart? So the Cushing now, high ACTH from the anterior pituitary, it causes high cortisol level, okay, and high aldosterone, and leading to high sodium and low potassium, okay? That's your Cushing, okay? So your Cushing patient has a buffalo hump, moon face, and purple striae and hypertension, okay? These are the in condensed summary of Cushing disease. So in order to break this down a little bit, anterior pituitary is what produced ACTH. So ACTH is high. It's produced in high numbers from anterior pituitary. And this causes high cortisol, high aldosterone, and these two now, M and G, cortisol is G, aldosterone is M. These two together, they lead to high sodium and low potassium. Now think about it, high sodium, that's hypertension right there, okay? So this is how you kind of break it down a little bit. I know there's a lot of highs and lows, but that's your endocrine system. It's a lot of highs and lows, okay? But pay attention to that. And now when we compare it to Addison disease, Addison is literally the opposite of Cushing. The way to remember Addison, I like this mnemonic, it's Addison, you need to add thing. You know, Addison starts with ADD. Well, Addison disease, you need to add things because everything is low. Addison signs and symptoms are low cortisol, okay, low aldosterone, low energy, hypopigmentation, and craving salt, okay? So what's happening here with the cortisol now, in order to make it more detailed, plasma cortisol will be less than 5 microgram per DL at 8 in the morning. So that's how you measure the cortisol level. In order to know whether your cortisol is high or low, you got to look for the plasma cortisol at 8 in the morning. And then aldosterone, what does aldosterone do? Low aldosterone means low sodium and high potassium. So keep in mind two things about this section. Sodium and potassium are always opposite, okay? High sodium means low potassium means high sodium, okay? And aldosterone, high aldosterone always means high sodium, okay? So every time you have high aldosterone, that means you have high sodium. Every time you have low aldosterone, that means you have low sodium. So this kind of tie all this together. And then when it comes to cortisol now, when your cortisol is low, your energy is low. Okay, and so this is how you compare the two between Cushing and Addison. And now it says order cortisol level to distinguish Cushing from Addison in the morning. So you need to order for your patient cortisol level at 8 a.m. in the morning. That's how you know if it's Cushing or Addison disease. And moving along to diabetes now, very, very, it's going to be on the test. Very common. So with diabetes, we have the diagnosis now. My mnemonic here is makes no sense, but it helped me, I think. I don't know, SROFA? I don't know. That's the best thing I could come up with. What do you think? What do you think I should change it to? It's hard. I don't know. I couldn't come up with any better mnemonic than that. But the key is that to diagnose diabetes, you need 3 out of the SROFA. Okay, SROFA is SROFA. So SROFA is 5 things. You need 3 out of these 5 in order to diagnose someone with diabetes. Okay, so the S, the first thing, S is signs and symptoms of polys. Okay, so everything is poly, you know, polyuria, polydyspsia, and polyphagia. These are the 3 polys, okay? Overeating, over thirsty, and over peeing. So remember I was saying SROFA is 5 things. That's right, but the first 2 has to exist together, in order for them to be counted as one of the 3. It's a little confusing, I guess, but that's how the diagnosis of diabetes is. And then the O is for your OGTT. It has to be over 200. And then the F is for your fasting. So FBG has to be over 126 twice. Okay. I wrote a little note there about comparing this with metabolic syndrome. Metabolic syndrome diagnosis is over 100 fasting. So the fasting blood glucose for metabolic is over 100. But we're not going to confuse ourselves with that. But I had to write it over there just because I didn't want to, I wanted to show the difference between the two. But to diagnose diabetes, the F in STROFA stands for fasting blood glucose over 126 twice. Okay, you got to do this twice. And if it's 2 times over 126 fasting, then that's a point. They get a point for that. And then the last thing in STROFA is the A. A is A1C, and it's over 6.5%. Newly diagnosed diabetes or diabetic patients with changing therapy, okay, you got to check their A1C every 3 months until stable, and then every 6 months. Okay, so when someone is new, you just diagnosed your patient with diabetes, he's a new diabetic patient, you got to check their A1C every 3 months. Okay, once the A1C is stabilized, then you check it every 6 months. Okay, postprandial goal for diabetic patients is less than 180. Okay, postprandial means 2 hours after a meal. Okay, that's the goal. Do not stop oral diabetic medications for insulin when sick or when going to surgery. Okay, they will ask you this question. This patient is going for surgery and he is diabetic. Can we withhold his insulin or should we give him his insulin? Well, do not stop or do not withhold medications or insulin, diabetic medications or insulin for patients. And then as far as carbs, eat simple before exercise and eat complex after exercise. And that's for the carbohydrates pretty much. And then we're going to move on to the 2 phenomenons here, the DON and the Somogui. I don't know how to say the word. You know what? I'm going to look it up. I'm going to look up how to say it because I don't want to sound like a weirdo. Huh?
Somogi.
Somogi. Oh my God, did you hear that?
Somogi.
Somogi. Wow. She made it sound so easy. Anyway, so the down phenomena is normal physiological high fasting blood glucose from 4 a.m. to 8 a.m. because of physiological insulin resistance in the body at that time of the day. Okay, this is how we are as human. Okay, our physiological body, we have a high fasting blood glucose level from 4 a.m. to 8 a.m. We have high glucose level. Okay, and this is only it's an insulin resistance, but it's a physiological insulin resistance. It's not pathological. It's not an issue. It's not a problem. It's normal. Everyone has that. It's a physiological, but if you increase your bedtime insulin, this won't happen. Okay, so in order to avoid this from happening, you get to increase your bedtime insulin dose. Okay, and then Somogi is abnormal high fasting blood glucose. So you wake up and you have a very high blood glucose level because you had a rebound from an over-treatment with evening insulin. Okay, to prevent that from happening, you decrease the insulin at bedtime. Okay, so just, I know they're a little bit confusing, I know, but just remember 2 things. In order to fix the dawn, you increase the insulin at bedtime. In order to fix the Somogi, you decrease the insulin at bedtime. And the second thing you need to remember is dawn happened because of physiological reasons. It's really because of the growth hormones. And Somogi happens because of insulin resistance because of glucagon that's produced by the pancreas that tells the liver to convert glycogen into glucose. Okay, and then here I added some little note about Charcot foot. Charcot foot might pop on the test. It's just a diabetic foot. It's a foot that has very decreased sensation, and it's a different deformity. It has a different form to it. It's called diabetic foot. But yeah, now we're gonna move on to the diabetic medication section. So your big guns, big one needs. I don't think this word is gonna show up in the test. Trust me, but you do have to know the class of the medication. It's your good old metformin. Okay, it is the first line of treatment for diabetes. You do have to know that. It is the first line of treatment. So the big side effect of that is weight loss. Okay, you should know that. It causes weight loss. Side effects of that is bloating, diarrhea, and it hits the liver and the kidney. So you got to monitor your kidneys, your EGFR, and your liver tests, okay? You hold metformin 1 day before IV contrast, and you hold it 2 days after IV contrast. Okay, why? Because IV contrast hits your kidneys hard. Metformin hits your kidneys hard. That's a lot of hitting for the kidney. So if you know your patient is getting an IV contrast, they need to stop metformin for 1 day. Don't resume metformin until creatinine is back to normal. That's kind of important. You need to know your kidneys are okay and running. The filter system is working before you can hit it with metformin. Don't give it to alcoholics because it causes lactic acidosis. And alcoholics tend to already have low pH to begin with. Okay, and that's not going to be good for them. Don't give it to patients with renal and liver disease and alcoholics. So this is your metformin. Metformin is important. It will pop on the test. So as long as you know these small nuggets about this medication, it will make life easier. It will make the test go by smoother. So the next class is the sulfo. The sulfo, I like to call them the GCG. Okay. And they promote weight gain. Now remember, they have G's in them, GCG, weight gain, okay? Pay attention to the G here, okay? And it causes high risk of hypoglycemia, okay? It also hits your livers and your kidneys. So now look at the comparing between the two, between metformin and the GCGs. Your metformin causes weight loss. Your GCGs causes weight gain. Okay, that's the difference. And then we move on to TZDs, which are your actose and your kiltazones, and they causes CHF. So when you put your patients on TZDs, you got to tell them to watch for swelling in the legs and swelling in general, any sign of CHF, because they do cause can cause heart failure. Questran is another medication for diabetes, and the side effect that you need to know about is bloating. Meglitinide, do not combine them with insulin. These are the two you don't combine with insulin. So these are medications not very common. I haven't used them in practice, but I had to put them in there because you never know what the test will throw at you. So Meg, REPA, and NATE, okay? I did bolded the MEG and the REPA and the NATE. At least I wanted to remember the first few letters of these medications so I can spot them on the test. But I can't memorize all these medications. Also, we have 3 other, so here I kind of grouped all medications that causes weight gain by the word sit, you know, because sitting causes weight gain, right? SIT, sit. It causes, it's the 3 medications that, diabetic medications that causes weight gain. So the S is your sulfo, and your I is your insulin, and your T is your TZDs. Okay, I hope this helps. The sulfos, again, you gotta know that it's your glipizide, and it's the GCG pretty much. Your TZDs, you gotta know it's your actose as well. So it's a little bit hard to keep up with these meds sometimes, but pay attention to metformin, the big gun, and pay attention to your glipizide and glimepiride. These are very common. And then we're going to move on to insulins. So when it comes to insulins, two things to remember. Logs are rapid. Think about logs, the pieces of wood that are on the water, they go rapidly. Just think about them going really fast. So logs are rapid, and being short is regular. Okay? Once you remember these two phrases, now I'm gonna explain what does that mean and how does this help. Logs are rapid. Logs are your insulins that end with log, your Humalog. Okay, Humalog is a rapid acting, okay? What that means is that the peak is in 30 minutes, okay? It covers only one meal. Being short is regular, okay? Which means the short acting ones is your regular insulin, okay? And it peaks in 3 hours. And then we have two more types that are easier to remember, your NPH and your Lantus. We all know Lantus already. It's the long-acting one, the one you give to your patients at bedtime. It doesn't have a peak, and you give it once in 24 hours. Now, the NPH, that's the one that you have to shake. You give it breakfast to dinner, and it peaks in 6 hours. So that's your insulins. The two that I confuse them the most are the rapid and the regular. I always confuse these words, but I felt like logs are rapid and being short is regular kind of helps a little bit. A1C goals. So now the goals, they might ask you in the test, okay, now tell me what are the goals when you're treating your patient with all these medications, you're giving them all these fancy treatments. What is the goal? What are we trying to accomplish here? So the A1C goal for gestational diabetes and diabetic type 1 is less than 6. Okay? A1C goal for older patients with diabetic 2 is less than 8. A1C goal for all other diabetic number 2 is less than 7. Okay, now I know I threw a lot of these numbers here for A1C. Do you still remember what's the number for A1C to diagnose diabetic? Well, I added it right there as a little star. It's more than 6.5%, okay? So you need more than 6.5% to diagnose diabetes. Well, it's one of the criteria, one of the SROFAs. However, the goals for A1C of the treatment is the ones that I just mentioned. So in order to memorize this, it's good to say, okay, most of them, so all the others, the majority are less than 7. So the goal is really less than 7, pretty much. But then when you do have your elderly patients that are really elderly, it's less than 8, okay? We don't want to hit our elderly patients with a lot of these meds. We don't want their insulin, we don't want their sugar to drop too much. And our A1C now for the two different ones, the unique cases of gestational and diabetic types 1 is less than 6. Okay, so this one's a little shorter, a little smaller number. And then I did a little summary here of the treatment for diabetes. So diabetic treatment, you start with metformin. Okay, this is really how the order of things work. So you start with metformin. You increase until the maximum dose. What is the maximum dose? It's 2,000 milligram per day. If A1C is still high, you add a sulfo, okay, which is your glipizide or glimepiride. Not both, pick one. If the A1C is still high, or even still high even on both on metformin and the sulfo, max doses, both POs, then you add a basal insulin, okay? That's your Lantus once a day. So you start off with your basal, with your Lantus. You order Lantus once a day. If the A1C is still high, then you add your bolus, okay? Then when you start adding your rapids and your regular insulins, okay? So this is really the order of treatments for diabetes. You don't just jump and give insulin to everybody right away, because the first line is metformin anyway. Another scenario, a child who is thirsty, okay? He has dyspepsia, and he urinates a lot and has weight loss and ketones in the urine and fruity odor. That's your textbook definition of diabetic type 1, especially it's a child, okay? Once they tell you it's a child having these symptoms of the POLIs, that's your diabetic type 1, okay? You make sure you catch that. And now we have a small note here about diabetic and the eyes. So diabetic and the eyes of diabetic patients has neovascularization. They have microaneurysms, and this is might be on the test. It's the cotton wool spots, okay? I'm not gonna sit and explain all these things. It's not a physiology course, but look these up. You can see the pictures. And then, but you gotta remember the cotton wools is your diabetic patients, because they're gonna try to confuse you with your hypertension patients, because they have their distinctive eyes as well, which we'll go over when we're talking about cardiology section. But for your diabetic patient, remember your cotton wool, okay? Soft exudates, fluffy patches, and then you also get the dot and blot hemorrhages, okay? Remember that word, dot and blot hemorrhages. And the hemorrhage appear orange-red in the center, okay? So this was a lot of words for me to remember. I was like, wait, you think I'm gonna sit here and remember all this? How am I gonna remember this? All these words that don't even make sense. So I created a little mnemonic, if you will, I don't know, a little statement. A dot blot soft orange cotton. Sorry. That doesn't make any sense when you say it. It sounded better on paper. It really sounded better. Okay, dot blot soft orange cotton. Anyway, these are diabetic eyes, okay? I don't know. Take it if you like it. If not, it's okay. We'll leave it there. Diabetes type 2, perform eye exam once you diagnose them at the diagnosis. With diabetic type 1, you perform eye exam 5 years after diagnosis, okay? And then that's really it as far as endo. I just have an extra stuff here at the end that I like to share with you guys. It's an extra mnemonics, more mnemonics. Let's do more mnemonics. So let's see, hypoglycemia is defined as the glucose less than 50, okay? It's in response to hypoglycemia. Okay, so in response to your hypoglycemia, the pancreas releases glucagon. So how do you remember glucagon? It ends with GON. Well, that's when the glucose is gone. I don't know. I think it's good, right? I don't like it. Okay, which stimulate the liver to convert glucagon to glucose, okay? So what's happening is that your sugar is low, okay? Your sugar is less than 50. That's not good. Your pancreas runs around and say, glucose is gone. Glucose is gone. Release glucagon. Release glucagon. And then the liver is like, what is going on in here? Fine, you want your glucose is gone? Did you just say your glucose is gone? Glucagon? Did he just say glucagon? Okay, then let's convert all of these glycogen into glucose. That's what the liver does, okay? Hypothalamus now. Okay, so hypothalamus has all these releasing hormones, okay? RH, releasing hormones. So we got your TRH, we got your GnRH, we got your CRH, and we got your GHRH, and we got your somatostatin, okay? These are your hypothalamus hormones. You remember hypothalamus produce a lot of hormones. Remember that from physiology back in the day, nursing school? Yeah, I'm bringing them back, baby. So in order to remember all of the anterior pituitary hormones, I made another mnemonics. Another mnemonics, guys. We can do this. It's, you better not laugh this time. This is not funny. It's Gample, Tish, and Fish.
This is the worst.
Let's break it down. Let's make this more educational, okay? Gample with a P, okay? Not with a B. Gample, not gamble. Gample. Tish and Fish. Okay, fine. Gample is your growth G. Now G in Gample is your growth hormones. Okay, anterior pituitary produce growth hormones. Just know that, please. A is for ACTH. Now, ACTH is the one that stimulates the adrenal gland to produce two things, the G and the M, the cortisol and the aldosterone, okay? The M in GAMPOL is your MSH, which act on pineal gland and it produces your melatonin, okay? This is a simple one. And then the P is your prolactin, produces milk. And then the L in GAMPOL is the LH, which is your ovulation, and it causes the production of progesterone, testosterone, okay? So LH, it does three things, OPT, ovulation, progesterone, and testosterone, okay? That's your LH. And then we have the TISH and the FISH, okay? What the hell is a TISH and a FISH? Well, that's just your TSH and FSH, that's it. That's it. TSH is your thyroid gland. It works on your thyroid gland to produce T3 and T4, and FSH work to produce estrogen. And that's it, guys. This is my best mnemonic ever. GAMPOL, TISH, and FISH. Okay. So what about posterior pituitary? No one talks about the posterior pituitary, right? It's not as interesting as the anterior pituitary, but it does produce two things, ADH and oxytocin, okay? ADH is your vasopressin. That's the other name for it. Remember these two? They're the same hormones. And it produces oxytocin, which induce uterine contractions and bonding between the child and their mommy. Now, the last but not least is phenochromocystoma, is an adrenal medulla tumor, okay? Random episodes of headaches and sweatings and tachycardia. So you got to remember that word. And last but not least, if a patient is complaining of hoarseness and dysphagia, I need you to start thinking maybe, hopefully not, but maybe thyroid cancer. And this concludes our endocrine section, guys. I'm so glad that you guys made it till the end. And I'm glad you stuck around. And I hope you learned a lot. I would say from the endocrine system, pay close attention to the hyperthyroidism and hypothyroidism. And pay attention also to diabetes, because these are very common. You'll see them in real life, in practice, on the test, everywhere. So good luck. Happy studying.